Got a bit of an echo there going. Okay, so it is the magic drop dead time of 1:30, so we will get going. So welcome to the breakout session with Dr. Daryl Wile on fatigue and sleep. If anyone is expecting something else, you are in the wrong space. Okay, you all seem to be staying in your seats, so I assume you've got the right spot. I'm Jean Blake, and I'm the CEO for Parkinson's Society, British Columbia. And I've got my colleague, Susan Atkinson, at the back, waving her hand, as well as there are a couple of volunteers. If you have any questions during or after the session, please feel free to approach us. So you all now have got a handout on your table called Take Home Message and an evaluation form. Please do fill that evaluation out at the end of the session and leave it on the table. And I'll move on now to introduce Dr. Wile, who's our presenter. He's very accomplished, and I have to say young man because of my age, and he is, he's very young. But he's got a Bachelor of Science in Psychology at UBC, a Master's of Science in Behavioral Neuroscience at McGill University, a Doctor of Medicine followed by residency training in neurology at the University of Calgary, certification in neurology by the Royal College of Physicians and Surgeons of Canada. He also completed a Clinical Movement Disorders Fellowship supported by Parkinson Canada, which Parkinson's Society BC contributed to, at the Pacific Parkinson's Research Centre in Vancouver under the supervision of Dr. Stossel. His focus was on genetic and brain imaging markers, looking at the clinical differences in Parkinson's disease. He has chosen to stay in British Columbia, moving to Kelowna, where he started the, we'd have to say the third movement disorder clinic in British Columbia, because Surrey, although they kind of came in under a different direction, is our second. He's continuing to build that program to address the needs of the Parkinson's community throughout that Okanagan area. So please join me in welcoming Dr. Wile.
Thank you. Yeah, and just to double check, so this is not the nap time station. If you were hoping to come here and get some sleep, I'll understand that's okay, but I'm here to tell you about fatigue and sleep disorders as they pertain to Parkinson's disease. Why? We'll come to that in a second. So this is what I'm going to tell you, though. So on one chapter of the book, we're going to look at sleep disorders. So how is sleep different in Parkinson's disease? We're going to talk about insomnia, dream enactment behavior, which you heard about this morning with Dr. Mapstone, restlessness as a symptom that can relate to sleep, daytime sleepiness, and then troubleshooting sleep problems. As for fatigue, we'll talk about fatigue, what that actually means, how it differs from insomnia or sleepiness, how common it is in Parkinson's disease, and some things you can do for that. So these are very, very important problems in Parkinson's disease because they're almost universal, and they also actually apply to many people without Parkinson's disease. So there are some general rules that we'll touch on as well for problems like insomnia, that can be important for caregivers as well. So fatigue, if you look at a group of Parkinson's disease patients, about a third of them say this is their worst problem related to Parkinson's disease. And then if you look at that group and you say, what are their top 3 symptom problems related to Parkinson's disease? It's in the top 3 in about half of people. So sleep problems are so common. Usually what we try and do in our clinic is when people get their movements kind of sorted out as good as we can at some time, we usually come next to that because it often winds up being the next biggest problem to address. Sleepiness is reported by about a third or slightly more than a third of people as well as being a significant problem. The graph on the right, the screen right, sleep benefit is the phenomenon where people will say after a good sleep they feel their Parkinson's disease is better controlled, at least temporarily, on average for about 80 minutes or something like this. But it is also the case that for almost every brain disorder, sleep will improve the symptoms the following day. And sleep is possibly also something that will impact neurodegeneration itself. because there are some things the brain does as kind of like garbage disposal and waste cleanup overnight in some of the deeper stages of sleep. So what affects sleep? So what determines how much you sleep, and why is it different in Parkinson? Well, so the time that you're awake, as you're awake, your body accumulates things called something called adenosine. So there's also another kind of protein called a SNP, or this is a new discovery in the last year. They found this type of protein they call sleep need index protein, or SNP protein, and those things accumulate while you're awake, and while you're asleep, those things reduce. So adenosine being one of them. So caffeine, fourth down on the list, one of the things it does is it blocks the effects of accumulating adenosine in your body and helps you feel more awake. Some people will say, well, I'm just a night owl. I'm just built that way. I'm kind of don't go to sleep at night. I don't fall asleep easily. And it's true that there are some genetic factors that determine how much sleep you need to feel rested, how much sleep you tend to get on average if you're not being woken by an alarm or someone's telling you when to get up for work and things. There are a number of those things. They can run in families. Hormones, so there are sleep hormones, sleep-promoting hormones, and wake-associated hormones. So we'll unfold that a little bit as well. So the awake hormones, you can think about generally. So cortisol has a day-night fluctuation in it. So in the morning, you get kind of a boost in the levels of cortisol while you're awake, and they sort of fall while you're asleep. Adrenaline is also, norepinephrine or noradrenaline is more prevalent during the daytime. And then there are hormones that are associated with sleep. And so the body cycle for a lot of these hormones is dependent on wakefulness and sleep. So one of the ways that you can alter those effects in the body is by what we call Zeitgebers, or time givers. So these are things that affect your body's internal clock. The most potent of those is scarce in this room. It's bright light. So we have these super bright lights, but it's not really the same as a full spectrum sunlight. So that type of light has an effect on your brain's body clock, and then that can affect the feeling that you need to sleep, and also the production of some of these hormone things. So natural light exposure, and then the other thing which is quite common is artificial light exposure, because it's one thing for there to be a bright light far away like that. If you've got bright light in front of your face like this, right before you go to sleep, it can actually also have an effect on your body's sleep cycle. And this is extremely common. It's, I think, about 80% of people use smartphones within an hour of sleep at night, at bedtime. That is not good for sleep because of this reason. So the light can affect your body clock. So a few things about sleep stages. So you hear people talk about REM sleep or REM sleep or REM behavior disorder, and I just wanted to go over some basics. What are these things referring to? This is an example of what you might consider a normal night of sleep. So let's say this is 8 hours from the first point here. I guess I should use the pointer. So from here to here, let's say that's an 8-hour amount of sleep. That's a pretty good chunk of sleep. So during light sleep, you can consider that the first and second stage of sleep. You get changes in body temperature. Typically, the heart rate will begin to decrease. Muscle activity will reduce. And then this deep sleep here typically occurs in the first half of the night, the deepest sections of sleep. It's when your heart rate is at its lowest typically, your body temperature is at its lowest, and your breathing and muscle activity go down. And there's maintenance things going on in the muscle, in the brain, in the rest of your body. The body's doing some maintenance activities. REM sleep, you can see, is interspersed between these little cycles. So REM sleep is up here because there are a lot of things about it that resemble wakefulness. So in REM sleep, your brain waves actually resemble what they look like when you're awake in many ways. That's when dreaming occurs and people have the experience of perceptible things. Normally, your muscle activity is absent during that time because there's an effect the brain has to sort of block the output of motor information to your muscles. And that can be impaired in some conditions, including in Parkinson's disease, which is why dreams are expressed as behavior, so vocalizing or shouting at things or moving muscles and things. So this again is an example of what would be normal sleep, but there are also changes in sleep with aging, and that can be considered normal aging changes. So whereas this is one kind of a similar example of a night of sleep in a younger adult, in an older adult it tends to fragment, so you get shorter cycles, they're more frequent, there tends to be more time awake while in bed, and there's less overall time asleep and more overall time awake in a 24-hour cycle. That's normal aging. So on top of that, there are further changes in certain brain conditions. So in Parkinson's disease, one of the really interesting things is that melatonin, which is a sleep-promoting hormone that's made in your brain, is not produced as much in people with Parkinson's disease, or at least not as we can measure it. This was shown in a study a couple of years ago where doctors took samples from the blood in people with Parkinson's disease, which is this black line here, and without Parkinson's disease, which is this red line, and they made curves. So they drew these samples every hour, so that you can imagine how fun that is. They kept people in an artificial environment, admittedly, so in like a hospital sleep type setting, and measured what happens with melatonin levels. So you don't get as a robust production of melatonin in this sample of Parkinson's disease patient, and it was particularly the case that they had a lower production of melatonin if they reported they were sleepy. They have daytime sleepiness. So that might be one of the reasons behind sleep disorders and circadian rhythm or day-night cycle disorders in Parkinson's disease. So yeah, as was noted this morning, I think a couple of times, so these kinds of changes in the sleep system can predate obvious motor symptoms like tremor or slowness or walking problems. And often people report insomnia because it's so common anyway in the general population, but if we ask patients that we're meeting who we think might have Parkinson's, do you have sleep problems? Almost always there is something. And there are some things that can be done about those things that can have a real impact on daytime function. So I wanted to touch on insomnia as it pertains to Parkinson's disease a bit more because I think this is the most common thing we try to tackle, and I've noticed a few common patterns that I wanted to share with you and my thoughts on these things. So what things can happen in Parkinson's disease that affect the quality of sleep? Some of them have to do with whether people can move adequately in bed, whether they have stiffness, pain, tremor in bed, so motor symptoms of Parkinson's disease. So some of them can relate also to medication effects, or treatment effect. So if people have good control of their treatment during the day, they take their last dose of medication in the afternoon or evening, and then they are taking their next medication the next morning, for instance, you can imagine that if that has some effect on their muscles of their body that help them shift or turn in bed or get up out of a chair or out of a low car or off the toilet, those things will prevent them from turning easily in bed. It can make repositioning in bed quite challenging, and people will feel it's hard to get back to sleep. The same can be true of tremor. So tremor can occur in the night as people enter those shallower stages of sleep. It will typically be absent in deeper sleep, but it can fluctuate and come on and off. It can wake the bed partner, or it can be, if it's quite violent or high amplitude, it can wake the patient. And then they can have a secondary insomnia, or they can have insomnia just from being woken by their own tremor during light sleep. Pain can be a symptom of undertreatment or medication wearing off or things like that, because stiffness and pain can often go hand in hand for people. And the interesting thing about this too is that anxiety can be a symptom, a non-motor symptom of wearing off. Oh, I skipped through a bunch there. So when I talk about wearing off, I'm talking about when people have a state of their symptoms where they feel like they're under good control, and a state of their symptoms they feel are not under good control. So as a shorthand, we sometimes we say that's on or off. And so some people during the day say, well, I feel about the same all day. I don't notice my medication kicking and wearing off, which is great. But in some cases that will then emerge at some point. And so if people have an on and off phase, usually we focus on the movement-related aspect of that. So when wearing off occurs, people will notice a tremor coming back, or they'll notice they're not walking well, or they feel unable to use their hands or their leg. But there can be non-motor aspects to that as well. Some of the most common of those are hot and sweaty, feeling hot and sweaty, which was discussed this morning as well. That can be a non-motor symptom of wearing off of medication. And anxiety. Anxiety, restlessness, and temperature changes are extremely common as wearing off symptoms, non-motor wearing off symptoms. And we often will see people saying that happens to them overnight. They get hot and sweaty, their sheets are soaked, they feel stiff, they get up to go pee and they can't get back to bed and they're tossing and turning all night. So in some situations we can work on that by doing medication or treatment adjustments. Sometimes that's effective. It's important though to also know that overtreatment can also cause sleep problems. So just like undertreatment can cause stiffness and slowness or tremor that can affect sleep quality, if people have accumulation of their medication effect through the day to the point they have unwanted movement in the evenings. Unwanted movement can go hand in hand with racing thoughts. Hard to get your head to stop thinking about things. Like we were talking about this morning, there's a parallel between cognitive symptoms and motor symptoms for many patients. And so getting your brain to say, okay, it's time to relax and quiet down, it's time for me to go to sleep, can be really challenging when it's ramped up like that. Also, dyskinesia, just having the extra unwanted movements that people can have can prevent sleep as well, or can affect the sleep of a bed partner. So, it's complicated. It can be from overtreatment, undertreatment. There can be things that are unrelated to treatment, unrelated to Parkinson's, just because you're getting old. There's so many reasons to not sleep good. But one of the main messages from this is that Parkinson's disease is a 24-hour condition. It doesn't stop when you go to sleep. Its symptoms are still expressing themselves. They express themselves differently at night, but many people need to consider their treatment as a 24-hour problem that they approach differently at night than they do during the daytime. Okay, so what's my general approach to treating insomnia in the clinic? So the first thing to look at is general measures that we call sleep hygiene or sleep behavior, and I'll dig a little deeper into that. And then we look at issues, as I mentioned, that we suspect could relate to medications for Parkinson's, like dopamine medication. Is there a wearing off problem? Is there overtreatment at night? Can we tackle some of the overnight stiffness or nocturnal slowness that people get because of medication adjustments? Then we'll look at some other common sleep disorders, and we might think outside the box, is there another separate sleep disorder that's unrelated? So what can we do medication-wise? So if people have fragmented sleep or this restlessness or this wearing off effect, sometimes some of the things we might do or we might look at changing the levodopa prescription if people are on levodopa. Some people prefer using a longer-acting, that's okay. Longer-acting levodopa preparation at night. It can last a little bit longer through the night. For some people, dopamine agonists can be helpful as a treatment for sleep. Sometimes that's not the case. It's not appropriate for everyone, but sometimes. Entacapone is a medicine that can lengthen the effect of levodopa. And then duodopa, we can maybe address in questions and things, but that's another option for delivering levodopa basically in a different manner. There are some medications, important to know, that can interfere with sleep, some Parkinson's medications. So the two main ones I look for if people are saying, I can't sleep at night, are when are you taking the amantadine dose? Or if you're on a medicine called selegiline, when do you take that? Because those in particular can have an effect on fatigue, which can be positive during the day, but if taken later in the day, can interfere with going to sleep, getting to sleep. So amantadine, I usually try to encourage people not to take that after the early afternoon, much like a cup of coffee. Same with selegiline. Not everybody has that response to these medications, but it could be a factor. Some antidepressant type medications can also contribute to insomnia. So I usually will look through the list and see if people are on one of these medications. So ones that work on a brain chemical called norepinephrine in particular can impact sleep in some ways. So these two, sometimes people report interfere with sleep. Bupropion, which is called Wellbutrin, or venlafaxine, which is sometimes called Effexor. And there are some other ones too, but those are two common ones that you might recognize. Some people use sleep aids at bedtime. There's not great evidence for this. There was a small study with this medicine called doxepin, which is an ancient medicine that some people said it was helpful for sleep for them with Parkinson's disease. It does have some side effects and things like that. It's generally best to not start with that kind of approach. If people have restlessness, sometimes we can treat that by adjusting dopamine medications, but there can be specific treatments also for restlessness. So you may have heard of gabapentin. That's a medicine that some people use for restless leg syndrome. So sometimes we can separately use that as a treatment for restlessness in some people with Parkinson's. It doesn't always work. And there are other things too. But so I guess if you're going to summarize this, so think about the Parkinson's medication. Make sure there's not other medications that could be affecting sleep. And then if you're in dire straits, there are things that can be used as short-term solutions for getting to sleep. But sleep hygiene. So this is sort of like dental hygiene. It's one of those things that you probably will try and think about just before you go to your appointment, like, oh, I got to brush my teeth for an hour today. I'm going to the dentist tomorrow. So sleep hygiene is one of those things that everyone says, yeah, we know. I shouldn't be using my smartphone in bed, and I shouldn't be watching TV before bed. There are behaviors that you can do that will actually help, but it's sort of sometimes a bit of a nuisance. But so this is the party line. So what do you do in bed? You go to sleep in bed or you use it for sex. Those are the two things that we say you should be using the bed for if you have sleep problems. If you're still awake after 15 minutes or so, then you get back up and you go do something that's really boring or non-stimulating. So that could be something like reading a book, or it could be just, getting out of that sleep environment, because that will allow you to avoid tossing and turning so much. But non-stimulating activities, some people use rituals like meditation. If you have that tendency to ruminate or perseverate on thoughts or ideas that are worrying you about the next day, a lot of people find it helpful to journal those things, to externalize them, get them down on a piece of paper so you can say, I can get that out of my mind and look at my list in the morning, and now I'm going to allow myself to forget about that because I know I've got it down on paper. Some of the things you can do during the day include limiting coffee. Alcohol, people will often describe as a way to help them get to sleep, but it actually creates a sleep state that's usually quite a bit less restful and interferes with deeper sleep. So it's generally actually quite counterproductive. And then, as I've harped on already, so bright lights from screens in front of your face right before bed are not good for your sleep-wake cycle, which is already maybe not working right in some people with Parkinson's. So I told you about this repositioning thing. So people will say, I can't turn over as easily. So I've got the satin sheet background on this slide because a hot tip a lot of patients like is they get satin sheets and pajamas, or silk sheets and pajamas, and you actually reduce the coefficient of friction on your body and the mattress. And actually some people find that makes a big difference for them being able to get comfortable. The other thing is the firmness of the mattress. I should put a disclosure. I have no personal interest in Sleep Country or any kind of mattress dealer or anything. But so softer mattresses, sometimes people say they sink down and then they just can't adjust correctly. So it's something to consider. There's changes to the physical environment for sleep can sometimes have an impact. You may want to consult your neighborhood occupational therapist and talk about ways that you can make bed environments safer or have assistance for turning and things. So a lot of people will get rails installed that will help them actually grab something to allow them to shift their body more effectively to transfer to stand. And then, as I said, the shifting in bed may sometimes respond to treatment adjustments. So if we provide people with a treatment change like at night as a trial, it's then sometimes the case you try that for a few weeks and then say, okay, is the problem as bad or is it a little bit easier? And then if it's not obviously better, maybe you don't keep that change. But if it does actually benefit you without drawbacks, then sometimes that can have a big impact on sleep quality and the symptoms the next morning. So another big one is bladder dysfunction or urinary dysfunction. And so as people age, like the sleep thing, it kind of gets more fragmented. Your hairs become gray. You get sore hips and things like that. So your bladder doesn't work right either. That's like a normal aging thing to some extent. But for people with Parkinson's, it can go beyond the pale. So you can say, I have patients tell me they have to get up 5-6 times at night to go to the washroom. How can you possibly do that and still get a good night's sleep? So sometimes this becomes a medical treatment issue as a contributor to insomnia or poor sleep. And if the bladder problem is better, people sleep better, and then their Parkinson's is better. So I'll give you an overview that I usually give patients about this. So the first thing you should do is make sure you're not drinking fluid before bed if you're getting up to pee multiple times in the night. It sounds obvious, but actually a lot of people don't do that. So it could also be even just little sips of fluid before bed with pills and things, but if it's a full glass of water, the water is going to come on back out at some point. Making sure the bladder is empty before bed. And then you have to decide, okay, which problem do I have here really, or do I have more than one problem? So in general, you can think of the kinked hose problem or like an overactive bladder type problem. So the kinked hose kind of symptom set is a slow, hesitant stream, like you've kinked the hose, the flow is low, it's hard to get it going, it's hard to feel like you've completely emptied the bladder. And that can often be from obstruction of the urinary system some way. So a common thing in older males is people say, you've probably got an enlarged prostate. You got a kinked hose problem and an overactive bladder problem. So the kinked hose being often in older males, like an enlarged prostate can, for instance, squish the outflow of urine. And people say, I can't get the stream going, it dribbles, it's slow to start, and I feel like I haven't got everything out. And then if your bladder's still half full, you'll be getting up again in an hour. So that's what we call sort of an obstructive problem. There's also an overactive bladder type of problem, which can be a feature of Parkinson's on its own, or from other conditions. So with this, people will say typically they have very short notice before they have to go to the washroom. They feel like an urgent need to go right now. They plan ahead before they go on a trip anywhere in the daytime. Where's the washroom? And that can sometimes actually also be a non-motor symptom. It's motor in a way because the bladder is a muscle, but it can occur as a component of wearing off for some people. So sometimes we see people describing overactive bladder symptoms that are levodopa sensitive or dopamine sensitive, interestingly. So there are some other medications we can use that treat overactive bladder. They would not necessarily be good for the other kind of urinary problem, might make it worse. So sometimes if the problem is tricky or it's a mixed kind of problem, you got to have a proper assessment of this by a urologist or get what we call urodynamics, where they can look at how the bladder is emptying, the speed of it and stuff. That gets really nerdy. But there's some doctors who are really interested in that, which I'm grateful for. The other important point here, I think, that I hope I emphasize is when people are up at night, it's a time then they're more likely to fall, actually, for a few reasons. One of them being, it tends to be a time when people have a bit less medication-related symptom control because people tend to bias medication in the daytime for obvious reasons. You're kind of up and about. But that means you might have a slightly higher risk of stumbling or tripping or dragging a leg when you're up at night. Turning can be a particular problem. So if you have trouble turning in bed, it tends to go along with posture and balance control problems, and those can manifest more than at night. The other thing which is common at night is after using the washroom, people can have a dip in blood pressure. And if people have low blood pressure to begin with, they've been laying down and now they've stood up suddenly and gone to the washroom and had a pee, that can be a time when you're likely to faint, actually, also. So these are practical ways that you can get around that. You can think about this and say, okay, well, if I'm going to get up at night, go from laying to sitting first. I can't really do that with my arm. Sitting. And then you go to standing. And you wait like 15, 20 seconds before going to the next position or going into your nice modern themed concrete bathroom environment where you're likely to hit something if you fall. So I mentioned before, so there can be other sleep things. So people with Parkinson's tend to generally be an older population, and they tend to share other age-related conditions that are common. So one of those is sleep apnea. So if people have in particular a thick neck or a higher amount of tissue around the airway, That can be a contributor to obstruction of the airway during sleep. Tissues that are softer will obstruct breathing inflow, and people can get pauses in their breathing followed by gasps. So usually the bed partner will notice this, and it's typically we say diagnose if people have more than 5 pauses an hour that are 10 seconds. So that's a harrowing experience for a bed partner or a loved one to experience if they are awake and they see someone not breathing for 10 seconds followed by a loud gasping sound. Okay, so that actually you would expect has some effects on the body. So it's usually associated with lower oxygen levels. People have measured shallower sleep, less quality of the sleep, so less restfulness. And it's actually more common in Parkinson's disease. So in Parkinson's disease, about 20% of people will have this diagnosed on formal studies, compared with about 5% of people age-matched in the general population. So it's more common in Parkinson's. So some things that affect the tone in the airway are important for treatment. And then there are a variety of things. So the air masks, so like that's why I have Darth Vader up there. So it's like the big mask. So if it's not clear what's going on, though, to unscramble the egg of insomnia, sometimes people need, like the bladder thing, they need a sleep study or a proper evaluation by a sleep expert. Okay, so I've already touched on dream behavior. I'll come back to it here for a second. So what is this all about? So, and what do we do about this? So I've told you, dream sleep or REM sleep, people will have vocalizations or movements in response. So I had one patient once tell me that his wife told me he was playing tennis in his sleep. So he loved tennis. So that was an example of a positive or a happy kind of dream behavior. Most of it, though, is actually not. Most of it is a fearful reaction to something in a dream. And it's usually someone being chased or an attacker, either human or animal. There are sleep specialists who study the content of dreams. This is not my thing, but it's interesting. They say it's more common for people to be chasing them than animals in dreams where people are doing dream enactment. But that's by far the most common. And so a loved one who's having a fearful dream response can also be scary for a bed partner. So what are some things you can do? So this is the pillow fort approach here. So we're starting with the kind of holistic non-medication approach here. So the pillow fort is pretty common, and it's actually often quite effective because the patient with dream enactment behavior usually does not know about it, really, and they're not really bothered as much by it. But sometimes it can be severe. A colleague of mine shows video he has and photos of a patient who was banging holes in the drywall in the home, knocking things off the bedside table. If there are things that are sharp, they have to take things out of the room that can injure people during sleep. So dream enactment behavior can be quite violent. Sleeping bags are another interesting idea. So this will allow you to have movements, but it will restrict the amount of movement you can make. It's a little bit weird, but for some people it works. And bed rails. Bed rails are a bit of a two-edged sword because sometimes if they're not constructed with like a mesh or something over them, they can be a way that an arm or leg can get trapped. And so again, it's a situation where sometimes a review by an occupational therapist can be helpful. They can help you figure out how to properly outfit things. There are some medical approaches. So one of them is melatonin, and one of them is clonazepam. These are basically the two things that we always talk about. Clonazepam probably works better, but it is addictive to some degree, and people can have a hard time not taking clonazepam if they've taken it for a long time. So you tend to try approaches that you can take a holiday from first. And so melatonin is usually easy to start and stop. So I'll tell people they could try it for a few weeks or a month, and then they can take a break from it if they find it's not effective, or do a dose-finding thing where they try one dose for a few weeks, then step back and say, is my sleep better? Do I feel more rested? Is my bed partner happier or not? And then decide, more, stop, or continue. So the way clonazepam and melatonin work are different. So melatonin, I showed you before, is like not produced normally in Parkinson's. So restoring kind of normal melatonin levels might be part of what's going on with that. It does seem to have a direct effect suppressing movements that people have with dream behavior. And clonazepam actually changes the sleep structure. So there's less dream sleep, actually. So that's one of the ways it works. A couple other points on this. So because REM sleep tends to happen later in the night, dream behavior tends to be most bothersome after 2, 3 a.m., like later in the night. What was the other thing I was going to say? It'll come back to me. Daytime sleepiness. Oh boy, 10 minutes. I've talked too long. Okay, I gotta speed up. Try Brightlight Therapy. There's some evidence that this helps with sleepiness, and it has less side effects than a lot of medical treatments. So people find it improves the sleep quality and measures of daytime activity. In Parkinson's disease, they've done activity measures and found Brightlight Therapy versus a red light therapy, which is a sham treatment where it doesn't stimulate the brain clock areas the same way. The bright light therapy helps people feel more awake more effectively, and it actually improves the amount of time people are moving with Parkinson's. So caffeine, there's sort of like a mediocre benefit to caffeine. So there was a study that was done to see if caffeine was good for fatigue in Parkinson's and sleepiness, and it was kind of maybe suggesting a subtle benefit, but it actually seemed to help motor symptoms. But then what we found is, in a larger trial, it doesn't really do that, and for some people, tremor is worse with caffeine if they have tremor, and caffeine can make anxiety worse, and some people find it affects their sleep by promoting insomnia. So it's still fielder's choice on caffeine. We've talked about this, I think, ad nauseum. There are some other medical approaches we'll use for daytime sleepiness, which I've mentioned. So selegiline and amantadine I mentioned. Risagiline is also called Azilect, is similar to selegiline. There are a number of studies on a medicine called modafinil, which is used in narcolepsy, and there is some soft evidence that it works. I think there may be an effect on some people with a particular sleepiness problem, but it's certainly not something we use in many patients. Okay, so fatigue in 10 minutes. Okay, so fatigue, what is fatigue? Well, why do I have yarn up here? Well, it's complicated. There's many colors in this ball of yarn here, that's why. It's a metaphor. So it's complex, it's hard to describe. People say there's more perceived effort to do an activity which should be easy, or they just feel a general lack of energy. How many people have fatigue in here at some point in their life? Probably just about everybody. And it's super common as a feature of Parkinson's. So this guy probably not fatigued. He's on his way though. So 20-25% of people report fatigue if you do a point prevalence. Parkinson's, half of people. I seem to think it's more. So fatigue, interestingly, in Parkinson's, does not depend on how long you've had Parkinson's. The prevalence is about the same throughout the course of the illness. It doesn't depend on the severity of the illness either. It seems to be the same in people with tremor and mild Parkinson's or early Parkinson's, or people with advanced Parkinson's and motor fluctuations and things. It seems to occur in similar rates in people who are on treatment and people who are not on treatment. So for that reason, you would think, well, it's probably not exclusively related to treatment. So what are some of the threads? I tried to match the colors of the threads here in my slide. So it can occur, like we were talking about with sleep problems, as a part of the off state or the medication wearing on, wearing off. It can occur as a feature of something called apathy, which we'll talk about. It can actually be in part related to sleepiness. They're overlapping and that you can't separate these two problems from one another. And then sometimes it's related to a medical condition, which I think is interesting, and usually we look for those things and try and rule them out and treat them. And then there's a je ne sais quoi, there's a whole ball effect. So there's something about the whole ball of yarn and fatigue that is not captured by all these pieces. If you add them up, there's more still. So this is an interesting one for me. So you talked about hypotension or low blood pressure this morning. So interestingly, fatigue is reported more commonly in people with lower blood pressures. That's the overall message of the slide. I won't really belabor it that much more than that, but people who tend to have lower blood pressures when they're standing, they may have fatigue as an earlier symptom as I'm going to faint. So there can be this general feeling of a loss of energy, or the energy to do things leaves you when you're on your feet. Sometimes that relates to low blood pressure. And we also know, interestingly, people have done cognitive testing on patients on a tilt table where they put them upright and they put them flat and they do cognitive tests. That sounds like torture. But in people with low blood pressure changes with position, cognitive performance is also better when you're flat, because if your brain doesn't have blood flow, it's not getting oxygen. You need oxygen to make the brain cells work. So that's an important thing. So it could be a subtle manifestation of low blood pressure. So it's important to know that blood pressure fluctuations can occur in Parkinson's as well as part of the on-off cycle, and the effect of that may be subtle. So if you have a problem that comes and goes in Parkinson's, even if it's not movement related, keep track of when it happens in the day, and then take that to see your doctor. For this kind of thing, I would say you should check blood pressures with your doctor, laying and standing in particular. Apathy. Oh my gosh, we could spend an hour on apathy. I'm excited about apathy. So fatigue, apathy, and depression often coexist. So I'm particularly interested in brain serotonin changes related to apathy. So there's a place called the cingulate gyrus where there are changes in serotonin in Parkinson's disease that may relate to fatigue. 5 minutes, okay. Dopamine agonists can affect reward experience. So dopamine's involved not just with movement, but with computing how much value is there in completing an activity, or how much reward is there in completing an activity, something that's good. Having a nice sandwich at lunch here today. Thank you for the food, by the way. So if the amount to which you enjoy that depends somewhat on dopamine. So there are people with Parkinson's for whom, when they're undertreated, they cannot experience the same reward and pleasure in normal activities. And when their treatment's working, they have a bit more motivation, and they get a bit more of a zip from doing something in life. So as you've seen as a common theme, a lot of these subtle changes in Parkinson's may actually be related to on-off fluctuations of medication. We know when people have DBS, if people have been on a lot of levodopa or other dopamine medication, and they suddenly drop the medication, apathy is actually fairly common. And so sometimes people feel like this loss of that lust for life. It can be like the honeymoon is over, what now? And it's been studied actually as a treatment problem in DBS. And it's reliably relieved by adding back small amounts of medication, typically a dopamine agonist. But as you've heard this morning, I think we talked about this a bit, dopamine agonists have other side effect profiles as well that we have to be careful about. Okay, so very quickly. So if you take a whole bunch of people with Parkinson's disease and apathy, some of them may relate primarily to depression. Some of them may relate primarily to cognitive problems or problems of the frontal lobe and its ability to drive motivated behavior. And then there's some people who don't have those things, and then sometimes we'll try bumping up the dopamine medication. So there's people for whom that doesn't work, so they don't have dementia, they don't have depression, they don't respond to more medication. And in some of those people, a medicine that works on a brain chemical system called acetylcholine. So rivastigmine or donepezil, another brain chemical system that's involved in cognitive function, can be involved for some people in apathy. So if we look at fatigue, so you're going to say, okay, well, which thing do I have? Do I have one or more of these different threads in the ball of yarn? And which ones of them can we treat? And which ones of them do we have to work around, essentially? So as general measures, people will say they have to manage their energy. So there's only so many things they can do in a day. They have to plan their day around the things they really want to achieve. And if you do that right, you can actually sometimes fit more into a day in the times that you're feeling like you've got the energy. Anemia, so low blood counts, low blood pressure. Oxygen's carried to the brain by red blood cells. If you can't make red blood cells because you don't have any iron in your body or something, we can fix that sometimes with medical treatments. But that's that same feeling like the energy leaves you and it's not coming back until, I don't know, maybe you've got to wait a while. But sometimes if we have a patient who has a thyroid problem, an underactive thyroid, that's another treatable cause of fatigue. There are some vitamin deficiency syndromes, particularly severe vitamin D deficiency can associate with fatigue. Vitamin B12 deficiency is often associated with fatigue. So these are things that we'll usually look for if people are struggling with fatigue. And then exercise, you've heard about so much. I'm not going to spend too much time on it. It's good. And then there is, as I mentioned, an overlap between fatigue, apathy, depression. So looking at the general things, we then look at the Parkinson's-related things. So is there a treatment change that can help with fatigue? Sometimes there's a foothold there, and sometimes we'll find a way to improve fatigue with medication adjustments. And then there's other things people have tried. The problem with a clinical trial for fatigue in Parkinson's disease is, as you would guess, Parkinson's disease is very different from person to person. And like many trials with these kinds of things, we look at big groups of Parkinson's people who want to recruit into a trial of fatigue, and they've got wildly different conditions, actually, and they probably have different reasons for fatigue, and they might be talking about totally different things. So we put them all on a medicine, and it sort of maybe works for some people. It doesn't work all that well. So it's really, I think, a better approach in this case to look at it more in fine detail rather than apply a single approach to most people. So that's, I think, why we've had sort of modest, success with applying new medications to these things. But for some people, a specific fatigue treatment medication might be an option. I got 1 minute. Complementary and alternative approaches. So actually, there's specific things with Qigong and Tai Chi for these things. Very hard to randomize people in such studies. So randomly assigning you to Tai Chi or a control group, well, you're probably going to know which group you're in. And then there's other things with dance, yoga, mindfulness, and things. And then, I've already touched on the exercise thing a bit. And there's actually studies of fatigue with boxing and music as well. So I usually say do what you like. Any activity is probably good as long as it's safe. So I'll take time for questions now, and thanks for your attention. Sorry about the AV. Yep.
Do you know if there have been any studies for helping people with sleep problems with THC tinctures?
Cannabis, THC, CBD. Yes. Great question. There's probably not enough time to address that in enough detail. I would point you to actually a lecture that was done at the Parkinson Society BC Provincial meeting, I believe, a year or two ago, which is on the PSBC website by Benzie Kluger from Colorado, who gave a really nice overview of this. That's about an hour long, a similar format to this with Q&A. I would say, many patients ask me about this. Many patients have tried it. I usually will give people the advice to be careful, like what exactly you're trying to fix. So what are your goals in using it? Change only one thing at a time. Give it enough time that you can be sure it's not just a good day or bad day effect. But do take a step back at some point and decide, am I getting the benefit I wanted from this new treatment approach? Are there any side effects? How much does it cost me? So if those things are all in favor for it, then that's fine. And I think your doctor will usually be supportive of that as well. Many people fall into different camps with that. And I do a whole 20-minute lecture on my perspective on this, but I think it's too soon to say broadly it's a good idea for many people or most people with Parkinson's. And there are some problems with how people are obtaining it and certain, how you know what you're getting and things like that at the moment. But certainly for some people it is effective. I've heard that before.
Hi, are you familiar with cognitive behavior therapy for insomnia?
Yes, the question is about cognitive behavior therapy for insomnia. So essentially it comprises a lot of what I was talking about behavior therapy or sleep hygiene approaches to sleep. It's got good evidence for helping with insomnia in the general population. I think it's probably a good idea to approach Parkinson's with the same mindset, but also being aware that there are issues that are unique in Parkinson's that might not really be exactly the same as a typical patient or person with insomnia. And so I think if you apply the general approach like that, and cognitive behavior therapy is known to be effective, if it doesn't work for you or for a person you know with Parkinson's, it's reasonable to talk about with a specialist, as they may have other ideas, or a sleep clinic actually might have other ideas that are specific to the particular needs.
I'm a bed partner, legal, and my husband has increasing nightmares. And I have been waking him up, but then he has a terrible time getting back to sleep. Any advice?
So let me first ask you if you've tried the pillow. Do you have the pillow fort?
Not yet.
You haven't got the pillows yet?
Yeah, no, but he has never hurt me, but he is clearly in distress.
Yeah, so I sympathize with that because it's so common. And a lot of people wind up sleeping in different beds and things like that because of vocalizations or because of movements. I usually, if it's appropriate for a person medically, will ask them to think about trying melatonin because it's fairly innocuous. If there's no benefit, it usually will not have much downside. Some people report more vivid dreams with melatonin, but less movements. So the patient might actually feel worse and the bed partner feels better. So it's one approach that is fairly straightforward is trying that for, again, a good chunk of time, and then taking a step back and saying, overall, is it better, worse, or no different for both of us? The physical barrier things I was talking about sound kind of funny, but actually that's practical, and for a lot of people that's enough. It's just preventing injury. Earplugs for the bed partner. If people are calling out, white noise in the room, sometimes that's actually sufficient. But some people do have a more serious kind of form of dream behavior that either needs more medical therapy than that or a more specialized approach. And so I've given you kind of 2 medical approaches. There's other things that kind of go beyond that, but that's where we would almost always start.
My question is related to sleep. Well, obviously, my sleep has changed in that I don't have a problem falling asleep, but I'll be asleep for an hour and a half, 2 hours, and I'll wake up thinking I've slept for 4 or 5 hours, and I'll be awake for quite a while and have a hard time getting back to sleep. I recently tried a natural sleep enhancer, and it's called U-Dream. I don't know if you've heard of it or not, but
the U-Dream product, I think, yeah, it has melatonin in it, and I think some other things as well. Maybe there's tryptophan in it and some other things.
Okay, and I've tried that with great success. My wife is concerned about becoming reliant on it, and I'm going to try the sleep hygiene practices that you suggest first, or try that again. And but at what point does the lack of sleep, the potential damage from that, outweigh the consequences of maybe relying on a substance like U-Dream?
I thank you for your comment because it reminded me of a couple of things that I think are worth mentioning here. So specific to the U-Dream, I would say it's a good idea to take it into your medical appointments or to your pharmacist to double check there's nothing in there that can interact with other things. So there are a lot of natural health products that contain ingredients that can interact with Parkinson's medications. Some of them have effects, for instance, that are similar to selegiline or rasagiline. And so because it's marketed as one kind of agent, on the back it's got 8 or 10 ingredients, sometimes there can be a complication there. So if you're taking anything even like a natural product, it's good to check with a knowledgeable pharmacist. The second thing that you reminded me I wanted to talk about was with this kind of problem where your sleep-wake cycle is not apparently working, that's a particular thing that will respond as well to bright light and exercise. So usually we'll, as part of the overall kind of sleep hygiene approach, we'd recommend people try early morning bright light. When you're sleeping as well, you're producing melatonin. It might be a lower than normal level, but when you turn your head position upright, it shuts off melatonin production. So people who are really foggy and sleepy in the morning, first thing you should do is actually sit up, even if you're still really groggy, because that will help turn down the melatonin system, and that can help with resetting your morning clock. In time, like over weeks and days and weeks, that can have the effect of helping you feel more sleepy at night. And for you, it sounds like getting to sleep is not a problem at night. It's the middle of the night thing. So that's that whole cycle. So if you do some things to improve the overall 24-hour cycle, sometimes your night of sleep can be better. There are also people, the third thing is the exercise thing. Some people say it's really good for them if they exercise in the morning. Other people prefer to exercise at night. People who exercise at night, sometimes they find that it interferes with getting to sleep. And that's a bit of an individual thing. But in general, exercise is also a good stimulus to let your body know when it's supposed to be awake.
So my husband doesn't have Parkinson's, but I'm wondering what your thoughts are on the sleep apnea machine, because he would be sleeping for 2 hours at a time or whatever, and waking up and hard to get back to sleep, and then getting up to go pee 3 times during the night, and blah blah blah. And he got tested for sleep apnea. He has the machine. He sleeps through the night. He doesn't get up and go pee. He's a different person. He's way happier. I just love the thing.
Yeah, some people have that experience where if there's untreated sleep apnea, it's like night and day. They feel much, much better. And there are trials in Parkinson's disease. So people with Parkinson's and a firm diagnosis of sleep apnea, we know that daytime sleepiness is better and insomnia is better if they're treated. Having said that, going on CPAP therapy is not always straightforward, and a lot of people find it uncomfortable. It's hard to find the right treatment and things, so usually you need a sleep specialist to help guide that. But thank you for your comment. I appreciate that. Yeah.
I just wanted to know your opinion about the Brightlight Therapy. I've seen some people with certain products that are out there. Do you have any well, it could be blue light. Sometimes it's not blue light. So I don't, some people think it's worthwhile. They're expensive machines, so I wanted to hear more about your opinion.
Yeah, so you're right. There is actually like a whole swath of things out there, and there are also some phony type things out there. So for instance, there are things that say, there's one thing that was, it was putting light in your ear with a headphone type device. And that makes no sense, but that company got money from a lot of people because they were making claims about it's affecting the circadian rhythm. So it is easy to fall for things like that are marketed to people who are unwell. So I do appreciate your comment. It's good to make sure you're picking something that's actually shown. So what I would look for is products that have some information that shows they have clinical studies. So there's, for instance, like Costco has a bunch of them, and they're produced by, I think they were from one company that was bought by a big multinational company that produces blue spectrum light. There's ones that are full spectrum light, and it is typically certain wavelengths and things, but it's ones that are clinically used for seasonal affective disorder. The same types of things that are effective for that are used for sleepiness and fatigue in Parkinson's. You'll have also the reference on that slide. I put the reference of the study, and I think there's information in that study what particular type of device they use, but I don't know what it is.